Thank you, Scott, and hello, everybody. Welcome. It's always great to be here. And I do start with a few minutes of discussion about a topic. Feel free to ask questions about that or about anything, as Scott said. I've been really trying to focus on tools and skills during this pandemic. And so one of my favorite sets of stuff is what therapists call DBT, Dialectical Behavioral Therapy, which is a whole big mouthful. But it has some really great components. And I just wanted to go over the four main components tonight. Just if you're not familiar with them, it's really something to look into because it was started in the 80s by a woman named Marsha Linehan, a psychologist. And it was really developed for borderline personality disorder, which is a tough population to work with, but it's been found to be applicable to all kinds of other populations, including addiction. But binge eating disorders and bipolar disorders and bulimia and major depressive disorder, PTSD, all kinds of stuff. But addiction is also really practical. And that makes perfect sense to me because DBT, or Dialectical Behavioral Therapy, is all about skills. And there's four different kind of component parts, which I'll just go over tonight. And I find myself, even without even being conscious of it, we'll talk to a client about this skill or that skill without really kind of putting it all together. But I think it's useful to talk about all of them. One of the core skills is mindfulness. And mindfulness is just simply being aware. And that's probably the most important strategy that we can work on with ourselves and with our clients. But it's just the idea of living in the moment and just really being aware of what's the input we're getting from our senses. What are we seeing? What are we feeling? What are we smelling? What are we, the sense of touch on our skin. And also, what's inside of us? What kind of feelings are coming up? And how is that reflected in our body? Is our stomach tight? Is our throat tight? Do we get a tension? Are we feeling good? Are we feeling sad? So it's just kind of a matter of being aware. And the most critical skill with mindfulness is to be non-judgmental. We don't want to say, oh, that's stupid. Why am I feeling that? Or I shouldn't be feeling that, or I always feel this. And it just, all that just takes us out of the present and imposes a judgment on it. So it's really important, just kind of observe, don't judge, and just be in it. And what's useful about this is when we get calm, and there is always a process, whether meditation or mindfulness, where we're kind of burning off random thoughts of like grocery lists and laundry things and unfinished whatevers. And after kind of all that quiets down, we can really start to observe ourselves. And this is the beauty of mindfulness with DBT, is because we can start to look at our negative self-talk and the chatter in our brain. We can start to be aware of feelings that, gee, I want to act out with porn now. And 30 minutes ago, I was feeling really fearful about the situation. And just, we start to make those connections that sometimes we as addicts don't. And so I think it's just a really critical skill. The second one is distress tolerance. And this is something I'm always talking about with my clients who are sex or porn addicts or chemsex addicts, because all of those addictions are all about intensity and really learning how to be intense and living for that, the intensity and excitement that goes with that, and the stimulation and distraction. So what really is a really important skill is to learn how to sit in quiet, to learn how to sit with maybe some uncertainty, to learn how to sit with boredom or unstructured time without feeling the need to kind of run from it and fill up the space. And so that, we call it distress tolerance, but it can be distress for other things too. It can be distress for feeling anxiety or feeling depressed or feeling uncertain or low self-worth or whatever those feelings are. If we can learn how to observe them non-judgmentally and start to tolerate them. So there's a couple of different techniques that are really useful for this kind of emotional regulation, I guess we could call it. One is distraction. Our brains, despite our ability to talk about multitasking, human beings can't really multitask. We focus on one thing at a time and we do rapid switching. And so if we're literally doing something, that I have a friend who juggles, believe it or not, juggles these little balls. And it's a perfect way to kind of pull your mind out because you're busy focusing on juggling. You're not worried about whatever the situation is or that triggering behavior or whatever. So that's one thing. Self-soothing, learning how to do it. And a lot of addicts do self-soothing with habits that are not great, right? So a lot of people masturbate for self-soothing or seek sex for self-soothing or seek a drug for self-soothing. So to learn how to do that without any kind of mood-altering or compulsive behavior is really important. Improving the moment, looking at how can we make this situation better? what agency or what power do I have to make an impact on that? And then pros and cons of tolerating distress. You know, should I sit in this? What am I getting out of sitting in this? You know, what could I get if I decided to kind of get up and make my bed and go out into the world instead of hiding out in the corner? You know, so it's a way of negotiating with ourselves. The third one, interpersonal effectiveness. You know, and what does that mean? I mean, basically, how do we relate to other people and how can we improve that? And a lot of what that involves is assertive behavior as opposed to aggressive or passive aggressive behavior. Just really expressing ourselves in a appropriate and assertive way. What's going on? For a lot of addicts, that means learning how to say no. Certainly for me, it means learning how to say no. Just somehow, most addicts don't feel they have the right to say no, or they'll say yes and then go do something else. Right? We don't have integrity with our word. So I think that's really focusing on keeping the relationships that we're in healthy. And a lot of DBT has these little acronym things that go on, right? So one, for example, for distress tolerance is TIP. TIP means, the T means tipping cold water under your face just to kind of wake yourself up. And that's a great way to kind of break out of emotional shock. The E means intensive exercise. We know that exercise is a great way to distract yourself and get other kinds of neurotransmitters and hormones flowing. And then the P in TIP would be paired breath, to do some breathing to kind of stabilize. The interpersonal effectiveness has another one called GIVE. Give for gentle. Remember, that's the assertive communication one. So GIVE as an acronym for how we relate to the people. Give meaning being gentle, don't attack or threaten or judge. Interest, show interest in someone. If someone's talking to you, but stay engaged, be there. You know, how many times have we heard partners talk about trying to hold a conversation with a sex addict and, you know, talking about something very important, their eyes are like wandering around, you know, the attention is not really engaged at all. Validate the person's feelings, and of course, try to have an easy attitude, smile, lighthearted, that sort of thing. So those are three. Then the fourth and final one is this emotional regulation, where we can really start to name feelings and that's really the critical first step, is identify what it is, and then do something about it. You know, we've mentioned here before that at Seeking Integrity, we hand out the little page in our client handbook with little emoji faces to kind of help people identify what they're feeling. Because notoriously, addicts have a hard time naming feelings, because we're not into feelings, right? That's not something we really kind of embrace when we're in our addiction. So I think to really name them, feel them, and if it's not something we want to be feeling, how can we change it? So basically, you know, it's like a bundle of skills, and you can break them down. You can use one, you can use four, and each of those four categories has numerous kind of skill sets within them. So it's a great thing. There's all kinds of literature on the internet about it. Just read it. You can see a complete review of the skills and all these little acronyms they have, and I think you'll find it's really, really useful.
Thank you, David. That's good stuff. DBT, what is the difference between DBT and CBT, and when do we know when one is more appropriate than the other? Just out of curiosity.
Yeah, so CBT is cognitive behavioral therapy. It's kind of the standard mode of psychotherapy, where we're looking at thoughts and feelings and the relationship with those, and how emotions really are the result of our thinking patterns. And if we can learn to change our thoughts, we can change the resulting feelings. It's very, in some ways complex, but in some ways kind of very simple construct to work with. DBT has kind of a broader sense of it. It certainly works with some thoughts, but it also starts to get into feelings. It gets into somatic or physical regulation. It's a kind of a broader, I think more effective set of tools. And the dialectical piece is a little complicated, but it basically, a dialectical process is have a thesis and an antithesis and a synthesis. So you have a state, a kind of a counter force, and some happy middle ground. And so as opposed to one kind of rule with CBT, DBT is all about figuring out sometimes opposing beliefs or feelings and how to kind of negotiate those and arrive at something that works for you in these processes and exercises. I find that DBT, the skills, and sometimes I won't even say I'm doing DBT, I'll just give people certain skills that are very effective with these addictions, meaning the ones we treated: seek integrity, sex addiction, porn addiction, chemsex. For the first month or two, I think it's safe to say, sometimes longer in the case of methamphetamine, our cognitive abilities are a little bit frayed. So we're a little bit kind of like we all have attention deficit disorder, or we're not thinking clearly. It's frustrating to try to read a paragraph and make sense of it, and we're a little scrambled and fuzzy. And so I think sometimes to try to do cognitive behavioral therapy with those folks is frustrating for everybody. And I think DBT has a kind of a better fit for these intensity addictions that we treat.
Yeah, but either way, behavioral therapy for a behavioral problem. I mean, rather than just sitting there and yakking about it for every day for hours on end with a therapist.
Right, and I think that's a really important point, Scott, in that we often talk about the relationship of trauma and other kinds of experiences as they inform or develop into addictions. And we know that trauma particularly is not just a cognitive process. It's a physical process. It's an emotional one. It resides in the body. There's memories of it and cellular memories. And so it's a complex process that won't be resolved just by talking about it. So I think that it's a broader set of skills that kind of have a more effective reach.
And there's a time usually down the road where more of a trauma resolution talk therapy, maybe not psychoanalysis, but has its place. But in the beginning, it's kind of about let's get this under control and develop some skills to keep it under control and then we go into the deeper, more painful stuff.
Exactly. And I think if you think about early recovery, I think probably the most appropriate set of interventions for that are crisis management interventions, right? People are usually in crisis. There's all kinds of consequences, and there's situations, and there's kind of extreme feelings, and so the best fit, I think, therapeutically are more skill-based crisis management, centering skills, breathing, coming back to the present, staying in the moment, getting through till tomorrow. And then once that kind of stabilizes, then I think the trauma work and the ongoing kind of deeper talk therapy can really be more effective.
Yeah. I always kind of think about, what was his name? Peck, Scott Peck, is that his name? And who defined sanity as a commitment to reality at all costs. And, in addiction, we define our behavior as insane, according to the 12 steps. And I always think about DBT as really sort of getting back to reality, and it's starting with the first component, mindfulness. What am I feeling? What am I thinking? Where is it in my body? All of that stuff. And then like doing something about it. Is that kind of how you see it, or am I off base? Or
Totally. And if you think about the first population that DBT was working with in terms of borderline personalities, a very difficult population that can go all the way up to sort of psychotic at times, but really highly emotionally charged and irregular, and sort of a push-pull in relationships and very stormy emotions. And so I think this set of skills, it's all about insight and calming down, giving skills. How can I kind of keep my behavior in check? And that's a perfect translation for addiction, where it's a similar, different cause, but same kind of set of symptoms on the outside.
Yeah, okay, thank you. Type your questions into the Q&A feature and we will answer them for you. We've got a couple here. The first one is from the house. When I say the house, I mean our treatment center. They're home after a long day of treatment and they want to know why we won't give them ice cream. It says, why won't Saul get us ice cream? David, you want to field that one?
All right, so there's been ice cream there before, so I'm not sure exactly why, but we have a wonderful chef at the house who does amazing food, and maybe on a lower sugar diet, I don't know. But one of the things that we are always conscious of with these addictions, and I think it's really important, is that there's a huge potential for transferring addictions. And I remember when I first got sober, I have trouble gaining weight, so this was an issue for me, but I looked around the guys that I made friends with like at our first anniversary, and most of them put on 40 or 50 pounds because they just transferred all that desire to use drugs and drink to other kinds of sugars. And so I think it's really easy to do, and we got to be really careful. So I imagine there's some kind of control on sugar, but beyond that, I don't know. It sounds like a conspiracy, though. So
take it up with Katie, chef. I put on 30 pounds in treatment. I was in treatment for 60 days, and I put on 30 pounds. So yeah, I think that's probably why we don't have ice cream in the freezer. Could you please recommend a workbook on DBT? I don't know of any, David. You may.
Gee, I don't know one offhand. The person that created it is named Marshall Linehan, Linehan. She might have, or her disciples might have one out. There's got to be good ones. I should be able to name one, but I don't know offhand. If you look around on Amazon or reviews, I'm sure you can pretty easily find which ones are popular with people. I should know that. I don't. I'm sorry.
Yeah, no, I'm sorry. I don't know either. So, I mean, our exercises are all pretty much DBT exercises that we do.
Yeah.
But we have our own manual that we use. So. Okay. Excuse me. Is addiction, in your professional estimation, a disease, a maladaptive behavior, or a moral failing? Or is it a combination of any of the above? Interesting question.
Wow. Okay. So I could spend the rest of the evening talking about the history of addictive concepts. First of all, let me just strike out the moral failing piece. I think that was a belief, back 50 or 60 years ago, and probably still in some conservative circles, it may be considered such, but addiction is not a moral failing. Addiction is a medical concern, a medical problem. So it's not about willpower or ungodliness or lack of morality or lack of courage or control or anything. Addiction strikes everybody. And if you look across the board, whatever socioeconomic status, whatever race, ethnicity, history, young people, innocent people, and everybody is affected by it. So I think it's certainly not a moral failing. Now it's interesting, how then do we define it, right? I think the model that's most popular right now and has been for a while is the disease concept, which really looks at addiction as a medical problem with a medical solution and not a moral one. And so that's an important concept. I think it's also simultaneously a maladaptive behavior. I think it's a way that addicts, and I speak as one myself in recovery, can disconnect from feelings and uncomfortable thoughts and our history and people and situations or whatever else we want to kind of avoid and not feel. And addiction helps us do that. It kind of pulls us off into another universe sometimes. And so I think it's definitely maladaptive behavior. And we can see, the addictions that we treat don't have a withdrawal per se, but I think when people stop doing it, you can see differences, certainly behaviors. There's, a lot more emotional ups and downs, or lability, we call it. Just people are up and down. There's sometimes tearfulness, there's irritability, and there's all kinds of symptoms of emotional withdrawal. So I think it's definitely a disease in that sense. It's a maladaptive behavior. And I'm going to throw in another one. It's not part of the question, but it's some of the current interesting thinking is looking at addiction as a learning disorder, meaning that when we think about addiction, what is it? It's our brains are doing what they know how to do. They're sort of seeking reward, giving us reward for things and doing it really well. But when we start putting in artificial behaviors or drugs that take that system and really hijack it beyond what it was ever meant to do, our brains are doing what they do. They learn, they reward, they say, this is good, let's do that again. And suddenly, though, we're chasing the wrong stimulus. And so I think there's some really interesting work. The Maya, whose last name I can never pronounce, New York Times writer, wrote a book called The Broken Brain, but about addiction. She has some really great writing about addiction. But anyway, there's some interesting theories and thoughts about that, about how the more we understand about neuroplasticity and neurology, the more we are starting to understand that a lot of these behaviors are just the brain doing what it's supposed to do, but kind of in a maladaptive way. So,
yeah, and there's a huge section in this book, which is the DSM-5, which is the diagnostic manual we use here, mostly dealing with addictive disorders. So they're diagnosable disorders or diseases. World Health Organization, I have the ICD-11, their diagnostic manual around here somewhere, but I'm not going to go looking for it. It also has a big old section that's really similar. So, you know, that the disease model, it certainly holds water because it's diagnosable and treatable. I tend to call it, and when I teach it in, you know, the Saturday work groups that I do, I call it a maladaptive coping mechanism because it's a coping mechanism gone awry. You know, we don't want to feel something. We drink, we use, we masturbate, whatever, to escape, and it just runs off the rails eventually. Moral failing, definitely not. Yeah. So let's see, where are we? Okay. Hi, Dr. David. Thank you for your service. My wife discovered my affair about 3 weeks ago, and the revelation has plunged her into severe PTSD. We might want to talk about PTSD and how that's actually diagnosed. She asked me to communicate with her daily, but all that I can say, including taking accountability, apologizing, and being transparent, triggers her. Any advice? This is really about crisis management. Very good question.
Right. So, yeah, so PTSD, of course, is post-traumatic stress disorder, which we normally think of as, you know, battleground and car wrecks and that sort of thing, natural disasters. What we are finding is that partners can experience PTSD, which is a trauma based on disclosure. And I think sometimes people kind of look askance at that, but when you think about the experience of safety and the experience of a partner who may have been in a marriage for 20 years and suddenly discovers that their husband or wife may have been having a whole secret life that they didn't know about for years on end. And it's just your world kind of the rug gets pulled out from under you. And so I think there's a sense of a total loss of safety. It's like everything I know is wrong and everything's upside down. And PTSD really has a couple components. One, traditionally, it has to be kind of a fear of death, a kind of a life and death feeling. And that's where some people say, well, partners aren't really fearing for their lives, but there's a sense of safety that is kind of feels like life and death at an emotional level when your life turns upside down. There's other criteria too, avoiding a numbing behavior or re-experiencing those flashbacks. And that pertains to, I think, what may be going on here, where you are trying to communicate with your wife and you say, all that I say, including accountability, apologizing, being transparent, triggers her. When someone is in PTSD or having those symptoms, they are re-experiencing, meaning that it can not even be direct words, but it can be something that reminds them of a threat that then they re-experience the full-blown kind of terror and trauma and emotional reaction of that event. So it's an extreme form of kind of unprocessed emotion that can sustain itself, you know, through these experiences. And so 3 weeks ago, I would say, I hope your wife is getting some professional support, because I think she's at a point now where somebody who really knows how to treat trauma and recognize it can really do some harm mitigation and, you know, not only help her, as you say, in this crisis, but prevent it from developing further. We know the quicker we intervene in any kind of trauma or traumatic experience, the better the outcomes. And so I think, I hope she's getting some kind of support for that PTSD, because it is treatable. But the other thing with that kind of betrayal and disclosure like that, or not disclosure, discovery, there's a trauma to that is quite severe, that really not only takes PTSD treatment, but it takes time and emotional support. And you may find that she's unable to deal with some of that. One thing in the meantime, I would ask her what she wants or what she could really use in terms of how you speak with her and what you say to her. So you could get some input on that. So to be as helpful as you can. And it may be to say nothing. It may be just to kind of not to be there even physically, but don't try to say words, don't try to explain, don't try to comfort, because there's a period of time when partners don't want to be comforted, they don't want maybe anything to do with you. And so sometimes we can make it worse. But I think I would check in and say, how can I help you? What can I do? I know this is incredibly painful. How can I help? So.
Yeah, and David, you differentiated a little bit between symptoms of PTSD and actual PTSD. One of the criteria for a primary criteria is the symptoms need to stick around for 6 months or longer. So she's probably not in PTSD. She's manifesting symptoms that will probably abate, hopefully, over the course. You know, she probably doesn't have PTSD, but she may later. As far as crisis management, I think David hit it on the head. You can't really manage this crisis for her. You can be very kind and, you know, ask what you can do, and you can try to be there for her, but she is going to feel whatever she feels at any given time. And if you try to control that, you're going to make it worse. You know, that's generally the experience of addicts. When they try to control the betrayed partner's reactions, that makes it worse. They do not want to be controlled right now. They do want to be heard, usually. The next one says, when I was at Seeking Integrity Los Angeles, there was a 2-pound tub of gelato in the freezer. Just saying, you're just rubbing it in that there's no ice cream there right now. That's not nice. All right, next one. I have been struggling with porn and sex addiction for years, and I'm now seeking treatment with couples therapy and therapy for myself. What would you recommend in terms of stopping porn and masturbation and potentially reintroducing it later with limits? Good question.
Yeah, great question again. I think, first of all, the therapy is going to be important for you, but I also hope you're going to some kind of fellowship and 12-step meeting or some kind of support group, because I think it's important not just to do therapy, but to really be in a group setting where you're accountable to them and yourself and can start getting some tools to help you put it down. I think it's really important. We can, I think oftentimes therapy is about the whys. Why are we doing this? And that's interesting and informative and helpful, but I think it doesn't bring you all the way home in terms of being able to stop that behavior. It's just not enough. And what's enough is the connection and accountability and being with other people who are going through the same concern, who can really mutually help each other as they try to move forward. So I think make sure you're dealing with this problem, not just with therapy, which is important, of course, but to also be in some kind of social connection where you have some mutual support. Ideally, and I think a 12-step fellowship would be great, plus some kind of professionally facilitated group is ideal. If you can find a men's group or a women's group of addicts where it can be guided and where you can go a little deeper into some of the issues. Those kind of things are really, really beneficial. In terms of stopping, I think, and I'll be curious about what Scott wants to say about this too, but I think just, really setting some time. I think people sometimes don't go long enough. I think it's really important to stop for a while. I personally recommend 90 days for people to both masturbate and porn and just not have sex for that period of time, to just kind of help everything cool down a little bit. That's not magical. There's no, for some people it's sooner, for some people it's much longer, but as a rule of thumb, that's kind of the general idea that I have seen over time. And to reintroduce then, I think it really depends on your circle plan, what your bottom line behaviors are, what role masturbation has. I think if you've identified as a porn addict, I don't know that you can ever safely go back to it. Just like somebody may be a meth addict, are they going to be a social meth user? Probably not. But for somebody who maybe for porn wasn't a central issue, and this is my belief, maybe that's something that could be a middle circle behavior. It just depends. And same with masturbation. In my kind of rule of thumb with masturbation, I would recommend take it off the table for a while. But when you do think about reintegrating it, I always go to what's the intention? Is the intention to kind of go off into some fantasy and disconnect and kind of masturbate and self-soothe perhaps and just have a fantasy off in La La Land? Or are you really connected with yourself? Are you present in your body? Are you feeling sensations? Are you having experience right here in the moment, connected to all your feelings as opposed to disconnected. So that's an idea. Scott, I'm curious what.
I think you hit it right on the head. You know, what are your bottom line behaviors? If porn is a bottom line behavior, if masturbation is a bottom line behavior, they're going to stay bottom line behaviors. You're not going to be able to do them recreationally in a healthy way. A lot of people, it's really porn that's the bottom line behavior, and masturbation kind of goes along with it. So eventually masturbation can be reintroduced. But if you really are a porn addict, which is entirely possible, it's kind of like gambling. It's like, no, you know, just stay away from it, because it'll drag you down really quickly. And I've seen guys, they're doing really great in their program, and they decide to reintroduce masturbation, and they're okay with that. And then they decide they can reintroduce porn, and they go off the deep end, and suddenly they're in relapse. So because they find out the hard way that it really is a bottom line behavior. So I would not reintroduce it without a lot of discussion with your 12-step sponsor, your therapist, your support network. Yeah, but it is possible for some addicts. Thank you for addressing what addiction is. AA sees it as a spiritual disease. You mentioned a medical disease. Could you address the difference? Is it one or the other, or a combination?
Right. So I think of AA basically talking about addiction as a medical disease, and thinking of it as, you know, the doctor.
Call it an allergy in the doctor's opinion.
Right. So I think that's the bottom line. Is it a spiritual illness or a spiritual disease? I think probably yes, there's that component, right? Because I think when we're active in our addiction, at least I'll speak for myself, when I was active in my addiction, I certainly was disconnected spiritually. And I think I was, had a lot of issues, religious-wise and spiritual-wise. So I think that it was certainly an issue. I don't think it was the central issue. And I don't think the big book is saying it's a central issue either. I can see the component of it, but I believe the approach is really, it's looking at something as a disease that has a cause and a solution, as an illness. But yeah, I mean, is our spiritual life impacted? Of course, yes.
I mean, step 12 of the 12 steps starts out with having had a spiritual awakening as the result of these steps. We tried to carry this message, et cetera, et cetera. And most people who work through the steps do have a spiritual awakening, but that doesn't mean a religious awakening. It doesn't mean you're going to church. It doesn't mean you have any kind of a system. It just means that you're aware that there's more than yourself in the universe. For me, that was a huge spiritual awakening. I was pretty sure it was all about me, and you all were just in the way and annoying. So those terms are pretty interchangeable, particularly in the big book. The big book, the founders of AA came from a very Christian background, both of them, and it does leak over into the writings of AA. Yeah, I don't know if that clarified anything. If my partner has an avoidant attachment style, how do we approach the issue of intimacy anorexia? We are dealing with BPD, which is bipolar disorder, sex addiction, and intimacy anorexia. Where do we start?
Okay. So first of all, there are different kinds of attachment styles, often correlated with anxiety, level of anxiety and level of avoidance or not, and how easily people move toward one another or not. So an avoidant attachment style would be somebody who basically probably goes for low anxiety and kind of a disconnected, autonomous kind of pattern in a relationship, kind of more doing stuff on their own, and not as much kind of team player stuff sometimes. So with that kind of style, I think really as painful as it is as a couple issue, the work probably has to start with the individual or individuals. Meaning that if someone's avoidant, if someone's kind of more autonomous, defaults to doing things themselves, to really kind of dig into that and see what's that about, what might help that. Is it anxiety? Is it trauma? Is it old pain and hurt? Is it abandonment? You know, there's all kinds of issues that that can be going on in that. And I think people really have to kind of start to resolve some of that to really move or shift the dial on these attachment styles. Now, if somebody's avoidant, does that mean you have to wait till you're healed to get back into a healthy relationship style? No, we can be doing that work simultaneously with learning how to engage and re-engage as in the emotional life of being a couple. I think, ironically, a lot of the skills that I mentioned as part of dialectical behavioral therapy are really appropriate for somebody trying to work through how to stay connected or attached if they're kind of more an avoidant style. A lot of that would be some of the affect, the emotional regulation piece, the mindfulness. There's a lot of tools that I think I would recommend working the individual work with, in addition to some of the trauma work that might go to resolve that. And then finally, there's couples work, and I think you didn't say if you're in therapy or not. So couples therapy can really do some powerful work in there, and a lot of that involves communication. Again, there's aspects of dialectical behavioral therapy that are appropriate. The communication style, the assertive, speaking of needs, the being gentle, not being aggressive, that kind of stuff. So there's all kinds of tools that can be used. And I think tools and skills can go a long way toward making this better. Remember what I said earlier, we can know why, we can do all the deep work and understand that, gee, I relate to people because XYZ happened when I was a kid, but unless we learn some new skills and behaviors, that information isn't going to be enough to really make a change. And we can learn those new behaviors before we have all the answers and all the information. So I think some of the skills, both as individual and then ideally a couples therapist who could really help. There's some really great techniques for communication, dialoguing with couples, and kind of training someone to be more empathetic in their relationship. And there's some really powerful tools out there for a couple.
I'm going to paraphrase this next question because it's kind of long. My recovering addict husband is sober from his addictions, but his rage and verbal abuse are the same as when he was actively addicted. He's not active in recovery right now, except for a couple of therapists and men's groups in the recent past, but those haven't helped with the rage issues. So any thoughts or advice here for this situation?
Yeah. So, rage and anger issues are never helped by addictive behaviors, and so they can be aggravated, especially if he's not in recovery from everything he needs to be in recovery from. Rage and verbal abuse, which is also mentioned here, are really, of course, never okay, and it's really almost a whole separate problem from addiction in terms of personality and some of those skills, often also stemming from trauma, but just a really kind of maladaptive pattern of explosive.
Can those issues get worse in early sobriety when the addict's coping mechanism is taken away?
Yeah, so this is a really good point, Scott, because remember, if we think of addiction as a way to manage our feelings and our emotions and our behaviors, then if we take away that coping mechanism, but before the skills of recovery are established and after we give up our addictive behaviors, that gap in there has all kinds of concerns sometimes. And one of those is that those behaviors can actually escalate because the controlling or the modulating impact of the addictive behavior, as bad as it was, is gone. And so I think the feelings are kind of bubbling up 100%. So I think it's, again, skills. The solution for anger and rage are skill-based groups. It's really important to deal with rage and anger in a group setting. It's really by far the most effective way to do that. Abuse, verbal abuse, which can easily spill over in other kinds of abuse, just never okay. And I think that's whatever kind of support you have to really try to set up boundaries and make sure that you're safe and that you're not putting up with abuse, whether it's verbal or emotional or whatever that takes. And that may take a separation, a physical separation, just to get the message home. But at this point, you need to really focus on your needs. And you don't mention if there's kids, but I think take care of you and your family. And the addict really needs to do some work on his own self.
Yeah, safety first for sure. Next one here. I have a friend who tried crystal meth 6 times and he doesn't feel addicted. He does say he's addicted to pot and he smokes legal marijuana every day in Florida. I knew I was addicted to crystal meth the first time I used it. Is it possible that some people would not get addicted to even the most addictive drugs? Do our genes or brain chemistry explain our drug of choice?
Wow, how much time do I have? Let's see here. So yeah, a drug like crystal, well, any drug. For a long time, it was thought that it was just the property of the drugs that were the sole explanation of addiction, and that if you picked up drugs like cocaine or methamphetamine, pretty much inevitably you would become addicted. Now, it's true that cocaine is an extremely powerful drug, huge amounts of dopamine released, and I would say that very few people can be kind of a social meth user. Meth is a powerful drug, and I think it's kind of too hyperbolic to say that, smoke meth once and you're in an addicted state. Because I have seen people that could use it maybe once or twice a year and seeming to carry on that pattern indefinitely, right? But what is that they're doing? They're using it usually at some party or event away from home. It's like a unique circumstance that's circumscribed and distinct. And somehow that serves as kind of a protective factor. Even given that, I think you're playing with fire if you use certain drugs, especially meth. Now, 6 times, yeah, I've had people who unfortunately relapsed and start to use it, and everything seems fine. And whether it's meth or alcohol, I've had clients go for 6 months of like, I'm using it again, it seems to be okay, no problem. And almost inevitably, it kind of escalates up. So I think we may be looking at a very short time window there. That person that used it 6 times might find that they lose control given some more time talking about it. However, if somebody's smoking pot every day, they may have just transferred that addictive urge to something else, and that may be what is the limiting factor on meth. If they're smoking pot every day, well, hypothetically, if we take away the pot, I wonder what would happen to the meth. It might increase a lot. So I think we do find people switch and get around. So then genes or chemistry, it's a really complex thing. The power of the drug is one factor, but as that experiment with Rat Park proved, connection, our social networks, there's all kinds of other factors that go into it. The drug setting that we're taking it in. There are people that use methamphetamine for weight control who don't ever associate with sex because they've never done it with sex, and it just never kind of occurred to them. I have a friend who was a male bulimic, and used methamphetamine for weight control. And when he got into CMA in Los Angeles, he looked around and heard all these sex stories. He was really jealous that he'd never had that experience, but it never occurred to him. So, it's not inevitable, but yeah, I think the addiction potential is certainly affected by our genes. That's true. By certain drugs, we know that certain drugs can flip switches sooner in our brains that kind of make us, there's no going back basically with addiction. There's certain genetic markers that are flipped and that you can't kind of undo that. So yeah, any drug like that, any addictive behavior is just playing with fire every time. And what I have found in over 20 years of working with meth, or 25, whatever it is, that even people that were never addicted, never caught up by any other drug or behavior, can get addicted to methamphetamine. I've seen it over and over again. The people that had no addictive potential, nobody in their family was an addict, they never gambled, alcohol left them cold, they never did anything, but boy, they've come across methamphetamine and suddenly they're hooked. So yeah, it's a combination of the drug, genes, where you're at in life, your social supports, all that stuff. It's a complex factor.
Yeah. I have a pet theory that there are 2 kinds of drug users. There are speedy drug users, and then there are downer drug users. And, I tried cocaine, I didn't like it. I've tried other speedy drugs, I didn't like them. But you give me something that's a downer, a depressant, and I'm all in. So there's nothing to substantiate my theory other than it's my theory.
Oh, no, there is. I do a whole thing with my clients. Yeah, when we look at these different neural pathways, there's a whole sort of arousal set of behaviors and drugs, and there's what we call satiation, the satisfied. So the arousal would be, meth, cocaine, ecstasy, porn, sexual acting out, gambling, shoplifting. It's all these very intense dopamine-driven behaviors. And the other side is more alcohol, opioids, binge eating, binge TV watching, sometimes marijuana. It's kind of sitting on the sofa with Fritos kind of thing. It's more the satiation, feeling satisfied. Two different directions totally. And I find that it depends on their pattern of what we call trauma response, but how people react to trauma, whether they're more the fight or flight people or the freeze people. And that really is two different camps.
Apparently I'm a freeze people. I also think certain things can go both ways. Even though alcohol is a depressant, a lot of people who like the speedy drugs also like alcohol.
Right.
And although sex and porn are intensity addictions, a lot of downer people like myself use it to zone out the same way we use TV to zone out. So I think so, but there's no mistaking it with meth. Meth is meth.
Meth is meth.
Yeah, yeah, you're gonna buzz around like a butterfly with meth. So that's it. Not even a good analogy. Butterflies don't move nearly fast enough. Hummingbird, that's what I was reaching for. My girlfriend and I are about a month post-disclosure from cheating behavior involving messaging women on dating apps, lying, exchanging pictures with women, etc. We are using many of Seeking Integrity's resources, as well as both individual and couples therapy. I made a promise to my girlfriend to abstain from porn and masturbation for 30 days, although we are both unsure if those behaviors were directly contributing to my addiction. After recently disclosing everything to our couples therapist, the therapist suggested that abstaining from masturbation may be more harmful than beneficial. Any thoughts on this and whether it makes sense to abstain?
Yeah, I mean, I kind of believe abstaining is the better way to go, just because it kind of breaks the cycle and some of the patterns. I know, I recently was in a conversation with somebody who was in long-term recovery from methamphetamine, who was saying, we tried the recommendation of no masturbating for a long time, and just found that he was relapsing on methamphetamine over sex, and that if he could masturbate, it took the edge off and he didn't use methamphetamine. The problem, I think, with that is that when we're masturbating, often if we're that close to our addictive behavior, it's really that kind of, going back to what I was mentioning before about intention, it's really kind of that disconnecting, dropping off into fantasy stuff, for the most part, in my experience. So I think, I don't know, I'd be more curious about what the therapist's rationale was, but I guess you have to make your own choice. In my experience, because a lot of those fantasies and stuff that are related to our addiction are so deeply grooved, if we're starting to masturbate too soon, we just automatically go there, and it just ends up reinforcing a lot of the addictive behaviors. We go there in our minds. And so, I don't know, I think it's fraught with some perils, and can kind of keep you stuck in place longer, is kind of my experience. But, your therapist probably had a rationale for saying that, so I don't know what that is.
Yeah, personally, I'm a big fan of stepping away from all sexual behavior, including with your partner. Talk about that with your partner before you do it for at least 30 days. My preference is more like 60 or 90 days. I think David's is as well. Mostly because it gives you some clarity. When I came in to sex addiction recovery, I had no clue what my problem behaviors were and were not. I needed to step away and get some clarity over what I'd been doing before I could figure out what was problematic and what wasn't. That's usually what we recommend it in treatment. But yeah, again, we don't know your therapist's rationale, but it's certainly worth asking about in therapy. So, thoughts on SAA, Sex Addicts Anonymous, versus SA, Sexaholics Anonymous? You want me to take this one?
Yeah.
Okay.
The basic answer on SA, but
yeah.
You can do it better.
Sexaholics Anonymous, they define what sobriety is for you. Sobriety, the only sex you're allowed to have ever in Sexaholics Anonymous is sex with your legally married partner. Masturbation is a violation of sobriety. You know, so it's not a good program for single people, particularly, unless you want to be completely abstinent. It's not a good program for people who are not married, but in a relationship, because every time you're sexual with your partner, you violate your sobriety. SAA, you define your own sobriety using a circle plan, which is what we recommend at Seeking Integrity. But if you are a straight married guy and you only ever want to have sex with your wife again, SA can be a wonderful program. Otherwise, I would go to SAA, but I actually encourage you, if you have them both in your area, to attend both and see which one fits better for you. But the primary difference is how sobriety is defined. SA defines it for you, SAA, you define it for yourself.
Scott, does SA, I somehow got the impression it was heterosexual marriage. Was it necessarily?
I think the language now is legally married. So if you're gay and legally married, I think it's okay. It was in the beginning kind of not the most gay-friendly program.
Right. Okay.
But I think I have been told that that has changed somewhat, but I'm pretty sure it depends on the meeting. So again, try the meetings out, see which one fits for you. Because ultimately you need to be comfortable in a 12-step room. Otherwise, you're never going to share honestly. You're not going to bond with the guys or women if you're female. So shop around. Is there any instance where you do not recommend counting days of sobriety? Interesting question.
Yeah, we're getting interesting questions tonight. So I think this is often a concern because I know with a lot of methamphetamine, for example, there's a lot of relapse. People get, some weeks or months together and then have a relapse and pick up, in Florida, it's a white chip, the newcomer's chip, 24 hours of clean time or sobriety, and, do that over and over again. It's kind of the walk of shame up to the front of the room to get your thing. And I think it can be very discouraging for people. I think a lot of people have the urge not to start their day count over again. I guess I'm old school in this. I think day counts are important. I think there's a certain kind of built-in accountability to it. So I think it's important, despite the potential for feeling pretty awful about ourselves if we keep relapsing. And I don't want to encourage everybody to feel shame or to shame anyone, certainly, but I think there's something about declaring publicly what we're doing and living by that that's somehow important. I understand the concern about it sometimes, but I think in the long run, the benefits of doing it far outweigh kind of not doing it.
And just to add to that, I think people with time, every year when I have a sobriety anniversary, I announce it in meetings, and I'm encouraged to announce it in meetings for an entire week. And the reason is, we want newcomers to know that long-term sobriety really is possible. It's not about me or my ego. It's about letting the newcomer know this is possible. This really does work if you stick with it and do the work of the program. But I know people who completely disagree with that. But I agree with David. I think it's important. Let's see. I think I said BPD earlier was bipolar disorder and it's borderline personality. My apologies. Sorry about that. If people are molded into addicts over time through a combination of genetics and trauma, does that not imply that they can work to fix and heal that behavior? The mentality and literature tends to be once an addict, always an addict. What is the scientific basis for that? And why don't people say that about other mental health issues like depression or anxiety? I think
great question.
But yeah, good question.
Yeah, so I think, I do believe that addicts, trauma gives birth to a lot of addicts and combination of genetics with vulnerability. So I think all that's true. The difference, and I think we're just really now on the edge of just huge discoveries about the brain. But what we do know is that there are, I mentioned earlier, in fact, the different genes, different genetic markers, different switches that addictive behavior and the impact it has on the reward circuitry of the brain and the brain changes that occur, physiological changes that occur as a result of addictive behaviors flick switches that actually kind of, the old, once you're a pickle, you can't go back to being a cucumber. There's some of that is true in terms of addictive behavior. So that's kind of the current thinking, is that once we cross a line with addictive behaviors or different addictive drugs, we're kind of always vulnerable to it. There's no going back. And so, and some of this we have the actual markers for, and others we're just, these are theories that we're kind of desperately searching for to find the actual mechanisms in the brain. But a lot of that is really happening very fast. So there's some really sound scientific data that show that addictive behaviors can really make permanent changes in the brain, even once we stop the behaviors and heal the trauma and heal the underlying conditions that may have set us up for addiction in the first place. Once we've acted on that, there's a genetic expression of that actually can change permanently some of our physiology or makeup. So I don't know that that's true, that same kind of flicking of switches is true for depression or anxiety or other mental health issues, for example, because we're not introducing kind of extreme neurochemicals or not tinkering with our brain chemistry quite the same way, although that'd be very interesting. There may be similar parallels that just haven't been really documented yet in the literature. But
and there are different kinds of depression and different kinds of anxiety. There's situational depression versus the chronic stuff that really is a neurochemical disorder, which really doesn't go away. You can treat it with medicine, you can treat it with therapy, you can learn coping skills, but you're always going to battle that neurochemical disorder. And that's kind of how I view addiction too. I mean, it's a kind of a self-inflicted, oftentimes, neurochemical disorder. But I think once as David said, once we flip that switch, I think the switch stays flipped even if we, pull the plug so it's not getting power, and we can do the work on healing our trauma. But life happens. There's always new trauma, and we can very easily plug that in. And I think that that in AA they say, my alcoholic, I've been sober for 20 years, but the alcoholic part of me is hiding in the corner doing push-ups, just waiting for an opportunity to come out swinging. And I've seen people with 30 plus years, even especially recently, as a matter of fact, people with long-term sobriety not be able to handle the stress of everyday life right now, and they've relapsed, and it's been bad in a couple of cases that I've seen. Yeah. So yeah, but the more work we do on the underlying issues like trauma in particular, the easier it is to stay sober. At least I'm speaking for myself. The more I know about my trauma and the more I work through it, the less triggering it is for me. But there's always new trauma that comes around the bend, and the old trauma that I think is resolved isn't quite resolved. Just life happens. And I've been sober a long time, and I still get triggered. Once in a while, not like I used to, and it's much easier to deal with now because I've done a lot of work. But I still get triggered. And David, you have twice as much sobriety as I do. You still get triggered once in a while?
Of course, yeah. I mean, yeah, life happens, like you said, and especially times like this. And the triggers can be subtle too. It can be chronic stress as opposed to a crisis. And yeah, we have to be really cautious all the time.
Yeah. So I'm sorry, everyone. We've got a bunch of questions left in the chat feature and in the Q&A, but we're out of time, so we're not going to be able to get to them. Please save your questions. Come back next week. David and I will be here Wednesday at 5 p.m. Pacific, 8 p.m. Eastern. Same link, and we'll be happy to answer these questions for you next week.
Sure. Really great, thoughtful questions. I love it. It's really true.
Yeah, really, really interesting session today. Thank you, everyone. So we'll see you next week.
All right. Take care, Scott. Good night.